This conference will now be recorded.
Good evening and welcome to AnCan's virtual support group for low and intermediate risk prostate cancer for Monday, December the 8th, 2025. A special welcome to our first-time visitors as well as our regular participants. I am Boykin Jordan, your moderator for this evening. I will be assisted by Bill Franklin, Stuart Jordan, no relationship, Dr. Janice Kushi, and our founder, Rick Davis. AnCan would like to note that this group is a peer-to-peer support group and should not be construed as medical advice. We are here to share our collective experience and answer your questions. We hope to provide you valuable information that we encourage you to discuss with your doctors. Before we begin, AnCan would like to thank our sponsors for all of our prostate cancer virtual support groups. They are Bayer, Novartis, Johnson & Johnson, Myred Genetics, Telex, Blue Earth Diagnostics, and Foundation Medicine, as well as thanking our participant base. If you would like to support AnCan, please visit our website at www.ancan.org. At AnCan, we have multiple prostate cancer support groups for our attendees. We have a group that's focused on active surveillance for those who are considering or have opted to postpone or avoid an active treatment. Tonight's group, which addresses those with low and intermediate risk that are planning for or have had active treatment. We do not address recurrence in this group and instead invite those people to join our high-risk, recurrent, and advanced prostate cancer group. We also have special groups for veterans and men under 60, as well as bisexual and gay men. With this, I will turn this part of the session over to Bill Franklin to pick up the interview with Martin.
One second. I was in the middle of typing. Thank you very much. Yeah, so Martin was here a couple of weeks ago, and we didn't quite get to him. We had another busy week then. So Martin was kind enough to share his biopsy report with me, which Martin, it was very easy to read. And John, I think you were going to share your Decipher report with Dr. John.
Yes, he did.
Okay, so I'll let John comment on that. So Martin's biopsy report only showed one positive core out of 13. I think 13 cores. One was positive. It was graded as a 4+3 Gleason, grade group 3. And at the time that you sent me this, Martin, you said that you had sent an email to consult with Dr. Epstein, but had not heard back from him.
Actually, in the meantime, yes, he sent me all the information to send to the urology department that did my biopsy, and they were then going to send the slides to Dr. Epstein. So okay, that's in the process of being done.
I was going to say, for the benefit of those other men that are new here, Dr. Epstein is, as Boykin pointed out, and his information is in the chat window. He is a highly renowned pathologist that gives second opinions on biopsy readings specifically for prostate cancer. And we urged Martin to send his results to him, especially with one positive core. It could make a difference in Martin's decision to pursue treatment or to go on active surveillance. So at this time, Martin, I'm going to say we really need to know what Dr. Epstein says, right? So,
well, true. I get that, but my daughter's getting married in May, and I want to do any kind of procedure prior to that time. I have appointments.
See, that's what we're saying. But I don't think you need to rush into anything. You had one core positive
Right.
in your biopsy, so you did have an MRI and it showed something, and they specifically sampled that core. Unless I'm thinking of somebody else. Is that what you told us last week?
MRI first,
Right.
then the biopsy, which was 4.4 plus 3.
And it was very
And then,
small. It was 0.5 millimeters, and it was less than 5% of the total biopsy. So that's it. It was graded 4+3, which, you know, that's grade group 3, and it's concerning. But out of the entire set of biopsies, it was just that tiny amount that they found.
correct.
So if it was me, and I knew then what I know now, I wouldn't be rushing to get any treatment without a little bit more information. And you'll get the second opinion from Dr. Epstein well before May.
Well, no, I understand that, but I'm talking about doing something in January.
Yeah. Okay. Anybody else want to jump in here? I can't say it any other way, Martin. I don't think you need to rush. I
Okay.
don't think you need to pursue treatment in January without further information. And John, if you want to talk about the Decipher score.
Well, Martin sent me the main Decipher score, which was only 0.16. So that taken with the 1 out of 13 core positive in a very, very small amount. To me, if Dr. Epstein agrees with the previous biopsy, I completely agree with Bill. Not only do you not have to rush to any treatment, but I don't even think you need any treatment beyond active surveillance.
Okay.
But we will wait and see if he agrees. But you're in a really good place. The Decipher report that Martin sent me also included a grid report, which, as you know, has pages and pages of very interesting molecular data from his biopsy, but it's not really to be used for clinical purposes, and even if it was, I saw nothing in there that would dissuade our impressions so far.
Okay. Well, thank you both for taking the time to look at that, and thanks for your advice. I appreciate it.
Yeah, and like we said, Martin, you're in a really good position. And everybody here, even the new, especially the new guys, right? We understand the diagnosis of cancer and how it makes you anxious, right?
Yep.
About what do I do next? How are they going to help me? How are they going to cure me if it's even possible, right? But we all have been where you are right now. And some of the other guys on this call are exactly where you are right now, right? They're brand new to this, and they're feeling the same thing you're feeling. You're in a good place, and to pursue treatment like next month would be, it could severely alter your quality of life, which you don't need. So don't do something unnecessarily.
Okay.
Now, my
I'm not a doc.
understanding is
That's not
that
medical
Dr.
advice. Keep in mind, but that's my personal advice.
No, thank you.
I think that Dr. Allen is, he's a radiation oncologist, if I understand right. I think he has talked to you about cryotherapy.
Dr. Alam, yes, he has. Yes.
Alan, okay. Alam. Oh, it's an M at the end. Yeah.
Right. And then it's Dr. John Kalpanik. I can't pronounce his last name, but he's at Northwestern too. I've spoken to him. And I do have an appointment, just so you know, on January 5th with someone who does HIFU at U of C.
Oh, okay.
All right. Does anybody else want to talk to Martin?
Yeah,
Mr.
Martin.
Rick. Oh, go ahead.
But Stuart and then Rick after that.
We'll jump to Rick.
Go ahead,
Hey,
Stuart.
Hi, Martin.
Hey there.
Uh,
since you've been talking to these doctors about cryo, and you've got this appointment coming up to talk about HIFU, one of the things that you want to be aware of and and think about, and also ask the doctors about, is the incidence of recurrence. Because when you're talking about a focal treatment where they're just aiming at treating exactly where the cancer is, you have two risks of recurrence. One being that it could come back where they treated, and the other one being that it could occur at a later date someplace else that hasn't been treated.
Okay.
And depending on this, the statistics can run as high as 1 in 2 that you will experience recurrence in the sometime in the next 5 years.
All right. Thank you, Stuart.
Rick?
Yeah, Martin, hello.
Hi there.
Welcome back to the group.
Thank you.
Question for you, because I missed it, I apologize. You said you have requested a second opinion on the slides from Dr. Epstein,
Correct.
but you haven't received it yet.
Correct.
Okay, well, I would agree with everybody that I don't think you should make any decisions on any type of treatment until you get that second decision, that second opinion back.
Okay.
If the opinion comes back as 3+4, I think even by most standards of care, active surveillance would be a very viable treatment option for you, with that being the only spot of cancer that we can see. And then you'd follow the active surveillance guidelines. Some of the guys in here can tell you what those are, but probably you could hold off getting a repeat biopsy, or more likely a repeat MRI, for at least 12 months. That would be the standard. If it came back and he confirmed that it was a 4+3, then most likely, I don't want to say most likely, I would say that whilst active surveillance would not be indicated, it might be a real option for you, and you can have the opportunity to speak to Dr. Epstein yourself. Okay. Somebody told me they called the other week and he picked up the phone himself. So if you do call him, don't be surprised.
All right, thank you.
Yeah, be interesting to see what he says. But I hearken back to Stuart's advice, which is that if you've got a 4+3 and you choose to do a focal therapy, the likelihood that it's going to recur somewhere else in the prostate is going to be very high.
Okay.
Don't be fooled by the fact that it's only one bit and it's only in one place. Whilst that you might be suitable to watch it for a while and see what happens, there's an equal chance that if you just treated it there, it might show up in another place.
Gotcha.
And the recurrence rate overall for all types of Gleason scores for any type of focal therapy is about 50%.
All right.
But if we could separate it out and look and see, we have to take into account that a lot of people get treated with who don't even need treatment with focal therapy, and they have 3+3s. So you could actually watch those 3+3s and to make up for that and the 50%, a lot of people who get treated who have higher than a 3+4 are facing recurrence.
Okay.
So it might be 50% for your 3+4, but for your 4+3, it's going to be higher than that. Notwithstanding, you still may be a candidate for active surveillance, but it bothers me when people do focal therapy, that it's really only appropriate for very few people. Stuart, I'll let you elaborate on this because this isn't really my area of expertise. Stuart, it is Stuart's. Stuart, go ahead. You muted. You got to unmute.
Mute yourself, Stuart. Yeah.
So, Bill, question, since you have biopsy, where in the prostate is the what section?
I mean, it's in one of the cores. I'm not exactly sure where. Bill, can you look for me? Because it's very confusing to me.
Yeah, it's the right mid-lateral was the only positive core.
Right, mid-lateral, so it's okay, so it's not overly sensitive. You know, and also the other thing that if you're going to talk to these doctors about focal, is make sure you fully understand the side effect profile of the treatment that's being proposed.
Okay.
They are not necessarily a walk in the park, and cryo happens to be the one that can have the highest side effect profile.
Really?
Okay. When I was investigating 18 months ago, and I was talking to a doctor, you know, there's an inverse relationship between effectiveness and side effect. The ones that proves to be higher effective has higher side effects, and cryo happens to be that one. HIFU is on the other range of the spectrum, and it has it has lower side effect profile, but it also has less effectiveness and higher recurrence. So make sure you talk to when you're talking to those doctors. Make sure you're asking them those questions about what their experience is and what you can expect.
Thank you. I also have an appointment with my urologist on the 7th. So hopefully having the other appointment, I'll be able to talk to him, specifically about these as well. So it times out pretty well in terms of talking to him. And I hope I hear from Dr. Epstein soon. But given that you said he actually may pick up a call, I can actually call him and see if he's even had a chance to look at it. It was sent out about a week ago, so I don't know how long it takes for the mail and everything because it has been mailed. But okay, well, thank you guys.
Usually about a 2-week turnaround.
Okay.
Within a 2-week turnaround.
Right, with the holiday and everything too. So
yeah.
All right, guys. Well, thank you all very much. Appreciate it.
Okay.
All right, you're welcome.
Okay, you're welcome, Martin. Okay.
Anybody else? Anybody else have anything they'd like to mention to Martin? Anybody else been thinking about focal and have any experience other than Stuart to contribute? Okay, moving right along.
Okay, so Steve, we're going to come to you next. I'm not sure since we muted you, I'm not sure if you can unmute yourself.
Yep.
Hello?
Oh, great. Hey, okay, Steve, I'm going to go through and ask you a series of questions, and we're going to get through the questions first on our side, and this is for everybody that's new, and then on the flip side, we'll give you a chance to fire back with your questions and we'll have a broader discussion. But we want to go through our questions first. And so some of these are going to just be basic data capturing for us. And what this allows us to do, everybody that's new, is level set from the beginning so that we can all approach this from a common perspective. So Steve, what's your last name, since we know your first name already?
Lewis.
Steve Lewis. Okay, great. How old are you?
I am 64 as of 2 days ago.
Happy birthday.
Thank
Or
you.
belated, yeah. What city do you live in, or yeah?
I live in Penang, Malaysia.
Oh, okay. You said Malaysia.
Penang.
Penang. Okay, got it. Okay, thank you. Okay. What was your PSA when you were diagnosed?
Well, about 2 weeks before it was 2.22, and then the date of when they did the DRE, they found kind of a hardness on one side, so we did another PSA, and it was 4.33. So it seemed a little odd because I had also had a infection that I had taken a course of Cipro for that finished like a day before. So I don't know if there was some, something going on that seemed to be jumping up
Right.
rather fast.
So, okay, got it. But 2.2, and then it went to 4.33. Okay. Did you have an MRI, or have you had an MRI yet?
I did that day, actually.
Okay. Do you know what kind of MRI they did? Just anything out of an MRI report?
I have the report. It was a 3 Tesla machine. So the details, that was October 13th. IRADS 4, lesion 1, size 22 by 22 by 36 millimeters, so relatively big. Peripheral zone 3 to 11 o'clock. It's mostly on the right and slightly on the left. So it just crosses the midpoint. Apparently the nerve bundles were intact and I didn't have any obvious. I don't know what SB stands for exactly. I assume it's I guess seminal vesicles probably. My prostate size it's normal. It's about 29.4.
Okay. Have you had a biopsy yet?
Yep.
Okay.
That was on October 21st.
Okay. Of November?
Of October.
Okay. Both in October. Okay.
Yeah. So based on that, I only had the one lesion that was on the right side. That was the big one we talked about. The Gleason was 3+4, grade group 2. It was 4% pattern 4, 60% pattern 3. I had 25 cores, 13 on the right-hand side. One was positive, and it was about 50% of the core. No PNI and LVI. And on the left side, 12 cores, all benign, no malignancy. So there was, though it crossed over, there was no indication that there was cancer on the left side, but to be determined.
Gotcha. Okay.
I did have. Go ahead.
I was going to ask how many cores were taken overall?
25.
Okay.
You said 25 cores, but only one positive one? Is that what you said?
Yeah.
Yes.
And it was perineal, and it was MRI guided.
Okay, and you already gave us your Gleason score? Okay. You gave us the percentage of 4, I heard was 60. Is that correct?
Well, it's 4% pattern 4. I think that probably meant out of all the 25 cores, but 50% on the positive core.
Okay, 50%.
Around 50. You're below, it says approximately 50.
Okay.
It's a fairly big number.
Okay. For your biopsy, was it a fusion, MRI fusion biopsy?
Yes.
Okay, just want to verify. Okay.
Yep.
Do you know if it was transperineal?
Transperineal, yeah.
Okay. And have you got a second reading on your biopsy slides yet?
I did. I got it from Epstein. I can kind of go through that.
Okay.
So I'll say he upgraded it, unfortunately, a little bit. He still kept me at grade group 2. He said 20% of the tissue involved 5 core fragments. I gave him all the slides that I had, the 20, oh, this whatever number slides, but for the 25 cores. And he said 20% of the tissue, 5 core fragments, 5% Gleason pattern 4. The troubling part actually was the second one, which was atypical introductal proliferation, AIP, which is great architectural complexity and or cyclo something or other, atypia. Then typical high-grade PIN falls short of strict classification for introductal carcinoma, prostate IDCP. The lesion in this case is a borderline between AIP and IDCP. And I think that's the sort of the high points. And then the one comment was pattern 4 in this case is large cribiform morphology, perineal invasion not identified, left prostate benign.
Okay, got it. Got it. Now, did you have a PET scan of any kind?
I did yesterday, and I'll get the results in a couple hours.
Okay.
So that's sort of the next step. I did have a, I'm not sure if I mentioned, but I did have the genetic test, the Invitae, and it was negative. My dad and uncle both had prostate cancer, so I was a little concerned on that one.
Okay. So okay, I copy on the genetics piece. Who do you have on your medical team? I'm trying to figure it out. It's a medical radiation, your radiation oncologist. Who is that? Do you have one?
Yeah, I do. His name is Dr. Chiat Sunway. They're pretty advanced here generally. They just don't have some of the, and I know based on what I heard, you guys aren't big on focal, but they don't have some of the focal treatments. So I'm looking in the U.S., but you know the options here for SBRT and some radiation and RP are pretty advanced.
Okay. And are you seeing I'm trying to figure out what the rest of your medical team looks like. Do you have like a radiation oncologist, a medical oncologist? Are they, not that you have to have them, but just trying to get a feel for who's advising you from a doctor's point of view?
Here I've got Dr. Chiat Sunway. He's a oncologist. He does radiation, and then I have a urologist. He did the MRI plus the biopsy at Island Hospital. He's quite good. I've actually had kidney stones, so I'm familiar with him from having those removed.
Okay. And I take it that your medical system is in Malaysia right now?
Yeah, but to be honest with you, I'm pretty flexible. I've actually engaged with a few folks in the U.S. Since I was sort of interested in focal, I was talking to Schianti, and I have a consult with him on the 16th.
Okay.
Somewhat to figure out whether I've got, if I'm eligible based on my current data. I also have a consult with Dr. Son at Stanford on the 16th of January.
Okay. Okay, so you have a couple of consults coming up. Okay, got it.
I did also talk to, or been trying to anyway, talk to Dr. I'm trying to remember his name, Klotz in Canada, which is kind of the active surveillance guy. I'm sure you guys know. And
Okay.
I've been trying to get through the admin there with not a whole lot of success yet. So they've got a lot of my data, but he was supposed to get a hold of me and hasn't connected yet. It's been rather frustrating trying to get through that one. But anyway, that's sort of number 3.
Okay, okay. And then just a couple last questions for me, and then we'll get your big question out.
Okay.
Do we have all of your contact information, your email and phone number? Do we have a way to?
I did put the.
Well, we collected his email address.
Oh, we did collect it? Okay, great, great, okay. And then how did you learn about AnCan?
I was doing a lot of searching online, and you guys kind of showed up as a good support group. So that's kind of why I'm here.
Okay.
I mean, I've gone on like groups like Inspire, you know, things like that, but I haven't actually talked to sort of other patients or whatever we call ourselves.
Okay, okay. So now that we understand a little bit more about your background and we'll know how to answer your questions, I see there's already one hand up from Rick, but go ahead and give us your question first, I think. Do you have a specific question you need us to answer for you at this time?
Yeah, I think some of them are sort of, how do I get support? You know, well, it's in a couple areas. I'm kind of interested in focal, but maybe not so much sort of the less invasive, but maybe, you know, based on my morphology or prognosis, you know, more whole prostate. I'm not, you know, given my age, and I'm sure you guys sort of feel the same, but I'm not too thrilled with the idea of dealing with ED or incontinence. And it's actually quite frightening, especially sort of early on. So I sort of jumped at focal. I'm kind of backing off that a little bit to kind of get a better whole perspective. That's actually one of the reasons I'm going to see Stanford. Apparently the guy's quite, you know, he's quite versed in a lot of different things. So I guess number 1 is, what do you guys think about focal? You know, I think my lesion is on the big side, so hemiablation is a maybe, depending on what the results are for the PET scan this afternoon. But probably more likely it would be whole gland. And then if it's whole gland, how does that start to look like, you know, RP? Because it's seemingly similar. So, you know, questions around focal, given my stats, you know, is that practical? I was hoping to do active surveillance, but because of that introductal stuff, that kind of frightened me a little bit away from that.
Okay. Okay, so I'm going to pause you there because I think we got a good feel, and I've already got a couple of raised hands up. So, Rick, do you want to go ahead and go? I see your hand was first.
Yeah. Again, please tell me what your Gleason score is. I know you said it earlier on and I missed it. What's your Gleason score right now, Steve?
It's 3+4. That was confirmed by Epstein as well, actually.
And it has already been confirmed by Epstein?
Yeah.
So the reason I put my hand up is stay well away from Chianti based on our experience. Yes, he's got a big rep. Problem we found with Chianti is that he talks a lot of people into treatment that don't need treating. And it's an independent private practice. He's got to make his money to stay open. And there is a huge, in our view, we've seen what we would consider to be a financial conflict of interest in people going to Chianti. So That I'm not saying don't consider focal, but if you're going to do focal, be sure that it's in the context of a center of excellence like Stanford or somewhere else.
Okay.
Don't go to these folks who have their own focal treatment centers set up, because there are a lot of men like you who want to do focal because they think it's going to preserve their ED and preserve their urinary incontinence, and for whatever reason they might not be best suited. Now, as a 3+3, yes, you would be a candidate. I can only tell you that we've just seen too many people who come back a couple of years later and they need treatment again. And by the time they need treatment, it may not be a 3+4 anymore. The disease has changed. And so for that reason, AnCan is not that comfortable with focal therapy, although it suits some men, and yes, it can work for some men. We've got a bunch of webinars. We've got a webinar from Klotz about focal. We've got a webinar from another gent about focal. If you just Google Klotz or you Google focal therapy, there's several webinars on the AnCan website. But let's just say focal is not everything it's cracked up to be.
Gotcha. Yeah, I kind of, I mean, I listened in the other day about I've heard the durability, so to speak, is not so great for focals. I mean, my dad, this was 15 years ago, but he had radiation. I think it was like 40 treatments. I'm not sure which version it was, but he was also on ADT for quite some time. I think in his later part of life, I think he got recurrence, and he was, but he died at 89, so maybe that's okay. Had a good life. If I could hit 89, I would be thinking I would be happy at this point. So, any other feedback on that?
Yes, Stuart has his hand up.
Hi, Steve.
Hi.
The fact that you're looking at a lesion that crosses over and could possibly could suggest full gland treatment is actually an issue that you would want to pursue closely. There are a number of doctors who do focal who don't do full gland. So you've got a slightly unique situation, plus the fact that Dr. Epstein's upgrade and the identification of the almost interductal plus the large cribriform makes this, possibly, a slightly more complicated scenario that, if you still want to pursue focal, I would pursue some of the very top doctors at the centers of excellence to get their opinion as to whether they would even recommend or do it, because they may say that you don't fit their criteria.
Okay.
The other thing is, since you're going to the Bay Area for Stanford, it might not be a bad idea to also try and get an appointment at UCSF, as if anybody's going to give you an opinion, a good opinion on surveillance, those guys would be in a good position to do that, or to tell you why they don't think it's a good idea. And the other my only other comment for you is on the radiation front. Today's radiation is so much different than the radiation that your dad would have had long, you don't necessarily, in your case, you probably don't need the 40 treatments. You probably can do SBRT in 4 or 5. And if you're 3+4, you probably aren't going to need ADT. So,
Okay.
I would, depending on what your preferences want to do, I'd look to talk to radiation oncologists at some of the, again, centers of excellence and get their take on how they would treat you, because you probably would want to do a test, do a prostate test for long-term risk of long-term side effects, but that might also be your option that keeps you away from incontinence and lowers the risk of ED.
Who would you recommend to talk to for radiation?
Well, if you want to go to Los Angeles, you could try and go see Dr. Keyshawn at UCLA. In San Francisco, Rick is Mac an option.
Who?
Yeah, no, yeah.
Mac,
I mean, you could definitely see Mac Roach, Roach,
Matt?
in San Francisco. I would, we'll connect you to a gent. I'm gonna send you his email. He's not here tonight. He spends about half of his time out in your part of the world.
Okay.
Not so much. Yeah, he is in Malaysia. He is in Malaysia, but he spends a lot of time in Singapore. And he's just opted for treatment. He was watching his 3+4 for a long time. He will get treated in San Francisco because he has another home there. But I think he'll be a good person for you to talk to. And I will put his email in the chat window to you personally and just tell him that the group suggested that he reach out to you. And he's talked to a lot of the radiation oncologists. He's looked at focal. He's done a whole bunch of things. He's not really considered surgery for various reasons.
Okay.
So that email out. One other thing you might want to consider is going to active surveillance and checking our active surveillance. And they're going to meet on the 10th of December at 8 p.m. Our time, and we can put that information in the chat window for you as well. Just so you get some information about that as you work your way through this.
One of the reasons I was pretty motivated to talk to Klotz was because of that. Because I wasn't, I mean, when I was pretty focused on maybe doing active surveillance until I saw that introductal thing, which kind of gave me a bit of a scare. So I don't know how to think about that.
Right. And I think the point of it is that with the active surveillance, they spend a whole lot more time with guys in your genre talking about that than we do at this group. So okay. You're likely to pick up more discussion right around that topic.
Okay, awesome. Did you? I'm sorry, I missed that. My bad. Did Epstein confirm you have introductal?
Well, he said borderline. It was basically. Let me go back and look at the thing for a minute. Too many windows. It said it was borderline IB or introductal and whatever the other one.
Crib reform. Yeah.
So neither of which I take it are very good, but it seemed,
Well-
I mean, he said 20% of the core, or 20%. The other guy said one core at 50%. So it does seem a little bit conflicting. But the other
I
thing
mean,
that changed for
if it's
me was,
clearly introductal, then probably it does need attention. If it's cribriform, it's slightly more aggressive, but you could do active surveillance with it. But I didn't hear the introductory part earlier on. That's my fault, not yours.
yeah, no problems. Just taking some notes as we go here.
Dr. John?
Yeah, I just wanted to, well, Rick really touched on what I was going to talk about. Nobody knows what features of introductal or borderline characteristics of introductal, nobody knows what that means.
Neither do I.
No. So it's, I don't think that we can either take it as a good sign or a bad sign, because the prognosis of that, whatever that pathology is unknown. Oftentimes, Epstein will be willing to actually talk on the phone with you, and you can ask him, does this mean anything?
Okay.
And we would be interested to know ourselves, because just speaking for myself, I have not heard a report that says features of or borderline introductal. And so I don't think you should let it have too much of an emotional impact on you,
Okay.
because its meaning is unknown.
Stuart, you have your hand up.
Yes, Steve, just following up on the Dr. Epstein thing. If you can get to talk to him on the phone, in this case, I would really ask him, because he's not shy to basically tell you his opinion on what this means. And, you know, he may be of a position that it doesn't impact whether you should be treated or not, or he may take the position that that from his perspective, and he's the guy who's understands this the most, that it really does require treatment. So I would really encourage you to try and get him on the phone.
Okay. But you guys think that active surveillance, I mean, depending on what he had to say, active surveillance is at least a possibility?
I would say yes, because we don't know enough about what borderline means. And so you're still, from my perspective, still in your gathering information stage. And so at this point, if I was in your shoes, I wouldn't charge off on a pretty fine diagnosis. Even, you know, I would try to gather the information first that could help you make an informed decision, a better informed decision.
Okay.
Yeah, and I'll add to that you know, yours, like Martin's and yours, what you see on all these results, unfortunately, it's right there. They're intermediate, right? So they're on the borderline, but neither one of them is an indication of anything that's highly aggressive, right? So you could wait a year and you're not going to die of prostate cancer. I mean, that's Bill Franklin's opinion. I'm not a doctor, right? But if you waited a year, you're still going to be alive, unless you know you're scuba diving and a shark gets you or something. But
Yes.
you're not going to die of prostate cancer in a year with this diagnosis. So you neither, Martin. So
Right.
don't rush. Gather your information. Get as much information as you can, because one thing I try to emphasize when I talk to guys is that any treatment that you get has side effects, and some of these treatments definitely alter your quality of life, and that's something you've indicated that you're concerned about, Steve. So, even if it's not the ones you indicated, there's other quality of life issues that could come from any of these treatments. So before you take that step, make sure you've got all the information you need, and you do not have to rush. You really don't. And again, we all feel you. We've all been there, and we know what the anxiety feels like.
Yeah. I mean, the other thing for me, just from a financial perspective, is, as I was mentioning earlier, I just turned 64, so it'd be nice if it's covered on Medicare.
Right. I just want to correct one thing that Bill mentioned. We're not that comfortable with intraductal. And I don't think we would encourage you to do active surveillance if you clearly had intraductal. The problem in your case is we don't know if you clearly have intraductal. So Stuart's advice was terrific, which is speak to Dr. Epstein and ask him, is this clearly intraductal? Because if it is clearly intraductal, then we would say, I suspect that we would encourage you to ask Dr. Epstein, does this need treating? Let's put it that way.
What's the best way to kind of get through to him on those kind of things? Is he open to calls? Okay.
Call him if the time difference works for you. Just call him, and half the time he picks up the phone himself.
Okay.
And if not, just leave a message and tell him you'd like to talk to him. You're following up on a second reading that he gave you on whatever date. And just since you're calling from out the country, you can say to him, send me an email and I'm happy to call you at an appointed time. Just bear in mind that there's 13 hours difference or whatever it is.
Yeah, gotcha. Okay. So no, I like I was saying, I mean, that was not to see that IDC stuff. I was not, I wasn't happy, actually. I kind of had a bit of a moment.
Right.
So yeah, definitely we'll follow up with him. And I hear you around the durability stuff with focal. I've heard that from enough people that that's a theme. So I am concerned about it, and I do hear that radiation has gotten a lot better. And I guess specifically around radiation, I'm
watching the time here, and I just want to make sure for the mods that they have. Could we be happy to come back to you, but we want to just try and get through it, everybody. I'd also just add, Steve, that if it is IDC, you're definitely not a candidate for focal. That would rule it out. But hang in and give us a little more time, and then we can come back to you again at the end.
Can I ask one more quick question?
No.
What
the reason no is because when we say we have to get on, it's because we're watching the clock. We've got several people, and we've just got to move on. We will come back to you if we have time.
Yeah, that was my bad. There's still 3 more people that wanted some time. Yeah. Sorry, Steve.
No problem.
Okay. Carl.
Hi.
Hi. How are you doing?
Pretty good. You have those standard questions for me?
Yes. I'm going to run through these. You've already heard them once, so can you just give us your last name? I won't ask you since I just said your first name. Just your last name, please.
Last name is Silverman, Silverman.
Yep. Your age?
I'm 70.
Okay. Where do you live? Like city, country, something like that? Yeah.
I'm in, I'm not there right now, but I live in Palm Beach County, Florida.
Okay, gotcha. Okay, great. So what was your PSA at diagnosis when you first?
Well, diagnosis of what? Of actual cancer or?
Yes.
Okay. Well,
yeah, yes.
well, let me just say that my initial PSA that was of concern was 4.4, and that was 5 years ago. Okay,
Okay.
5 years ago, and it has wavered and gone up slightly each time, although it's went down a couple of times, but it reached 9.0. I think it was in August, okay, this year. So over 5 years, it went from 4.4 to 9.0. Now, my urologist, well, go ahead and finish with the questions, and then I'll.
Okay, well, we'll probably come back to that. So, but that's good
Okay.
for right now.
Okay.
I'm sorry, did somebody say something? Okay. Okay. Have you ever had an MRI?
I've had several MRIs.
Okay, let's do your last one. Let's focus on that one.
Okay, well, the last one was a X4, and it was a 3 Tesla, and the radiologist who read it found one lesion. However, the urologic radiologist who did my biopsy just 4 weeks ago, when she saw the MRI, she goes, "It looks like there's another area I want to take a look at too, in addition to the grid that she would use." Anyway, so it turned out there were 2 lesions, and the main, well, neither lesion has reached the capsule. They're both in the prostate, and one of them at least is abutting the capsule. But my previous MRI was 3 years ago. Okay. What happened was in 2020, I had an MRI. 2021, I had an MRI. 2022, I had an MRI, and it was just the PSA was just going up a little bit time, and it was PIRADS 3 in 2022. But now supposedly it's PIRADS 4. I won't speculate on why that is, but I lost my train of thought here. But anyway. But so it went from PIRADS 3 to PIRADS 4 over those 3 years. And I have basically been in active surveillance for the whole 5 years.
Gotcha. Okay. So have you had well, you've obviously had biopsies if you've been in,
yeah, I put off the biopsy until recently, until a month ago. And I had a transperineal fusion biopsy with the ultrasound, rectal ultrasound. And she found the one most concerning lesion. And then, as I said, she found another one too. Of the I think she took 14 cores. Here. I think she took 14 cores. And the main core was a 4.3 on the left side, and that had 50% of the tissue volume was cancerous. 70% was Gleason score 4. And then also, that was on the anterior apex, and then also on the left side. These two are on the left side. On the left side, at the base, anterior base, there was a 3 plus 4. Okay. Then you go over to the right prostate. There was a 3 plus 4, and the left prostate lateral, there was a 4.3, and it was 40% of the tissue, and 80% was Gleason 4. I also had a decipher come in just a few days ago.
Hold on, let's back up.
Sure.
I'm losing count of how many lesions you.
Well, I think they're actually 2 lesions, but of all the.
So there are 2 lesions, and then
items, there are 14 items listed on the report.
Right. Okay.
last ones say, prostate lesion number 1, X9 times 9 core biopsy, and that was 4 plus 3, involving 6 of 9 cores. Okay, so that sort of deals with as looking at the whole lesion, and the other just deals with the individual cores.
Okay. Okay.
So
We'll come back if we need to dig deeper into that. And so,
okay.
your Gleason score is a 4 plus 3, is what I heard.
Most of the samples that had cancer were 4 plus 3.
Okay, gotcha. Now, this biopsy, was that an MRI fusion?
Yes.
Okay. Was it, and you told me earlier, I think you said it was transperineal?
Yes.
Okay.
I think it was an ultrasound fusion from what I heard before.
Yeah, it was based on, she had the MRI data and disc, and she fused it with the rectal ultrasound. Did you understand? It was transperineal.
Yeah.
Okay.
Yeah.
Okay. So make sure you understand.
Okay. So have you gotten a second opinion on these biopsy slides? On your...
No. I'm not even sure that I'm going to waste my time doing that, because I think with all of these samples that were either 4 plus 3 or 3 plus 4, and it being on both sides of the prostate, I think I need to take some action on it. But what I was concerned about was I've consulted with the local. Highly recommend.
Wait, hold on. Let me keep going through the quickness.
Oh, okay.
We'll get there. Yep. So let's go about PET scans.
No, none, not yet.
No PET scans. Okay. I've heard radiation oncologist. Do you have a medical oncologist as well?
No medical oncologist.
Just a and then a urology oncologist, maybe?
Urologist.
Or urologist?
Well,
okay.
Urologist, and then the doctor who did the biopsy was a urologist.
Okay, great. And then in Palm Beach County, what medical system are you in?
Oh, it's all independent from me, but I got yeah, pretty much. I mean, I got the biopsy done at Boca Raton, which is Baptist Health, but all the other facilities are,
okay.
There's no college related facility.
I'm understanding you're not tied to a system. Okay.
Correct.
Okay. Great. So last two for me, and then we'll get your question.
Yeah.
You hear about us?
Just like one of the other people said earlier, it might have been in some kind of bulletin board somewhere, or just Googling. I don't recall.
Okay. Thank you. And then, do we have your contact info, email, and did we collect that already from you?
I don't know. But if you give me an email address, I'll send. I don't want to broadcast it here, but
gotcha. You can send it to me. I'll put mine in the chat.
He can send it to me. Send it to me, Boykin, since I'll
send it to
process everything anyway. So
okay, Bill, will you throw that in? I can't see. Yeah. Thank you, Bill.
Where are you putting it? In the chat?
It's in
right
the chat
at the very
window.
bottom.
Oh, I see. It came up here. Okay.
Yep.
Okay, you got it. I'll do that later this evening.
Okay, great. Yep. Just your contact, that and cell phone. Okay, thank you.
Yep.
Then, what's your questions for us?
Well, two areas. One area was, and of course, I've been listening to the comments about these various sort of alternative focal therapies, such as HIFU and Tulsa And I actually contacted a doctor up at Mayo Clinic up in Jacksonville, which is like a 3.5 hour drive, 4 hour drive up there. And he looked at all my paperwork, and he goes, I can't help you. I don't do bilateral HIFU. Okay. And bilateral.
Bloody time.
I'm sorry?
Oh,
Thought he said something.
no, I think there's,
That
I
was
don't
something
think that
else.
was for us. Sorry, go ahead.
Oh, okay. I didn't know what that was.
You said,
So, but anyway, he doesn't do bilateral. Okay, he would only do it if it was one side. I think that was for Tulsa. I think he was Tulsa procedure guy. I don't know why he only does one-sided unilateral, I guess, procedures. But anyway, so that rules out Mayo Clinic. I do have a brother who lives in Chicago, so I'm going to pursue University of Chicago, and I have some recommendations there that I'm going to ask them about. But if those alternative kind of therapies don't pan out, my radiation oncologist here will do 30 sessions, 6 weeks, 30 sessions. It's not far away from me. It's only 6 miles away. He says he does 500 a year there. And he was the only reason he was discouraging me from HIFU or Tulsa. He says it just doesn't have a long enough track record yet. But my urologist was sort of pushing me to get the ADT during this this radiation treatment. And my problem is, and this is one of the reasons why I don't know what my genetics are yet, is that in my family, virtually all of the men, except for my brother so far, who's a little bit older, all the people in my family, including me, had early heart disease, and most of them didn't live to my age of 70. My father was 43. So if they had lived longer, they might have gotten prostate, but we just don't know. I did do another.
oh, hey, Steve, I'm losing you, Carl.
Where I'm going on this?
No, your sound, I couldn't hear you.
Oh,
Yeah.
Let me jump in a second, Carl.
Sure.
Yeah.
First of all, you don't need to go to Chicago for treatment. You've got great treatment at Sylvester. You've got very good radiation oncologists who understand.
Where is Sylvester?
Miami.
Oh, I won't go down to Miami. Sorry.
But you'll go to Chicago.
Because I have my brother down there, and I just
Well,
stay
wait a minute,
there.
but okay.
And it would now remember I would only do it. I would only go to Chicago if they could do HIFU or Tulsa. And
look, if you've got a difficult case of cancer, if you want to get the best treatment, we need to get to the best doctors. If you go to Chicago and you go to Northwestern, you're not going to be in a great situation. If you go to Chicago and you go to University of Chicago, you may be in a good situation.
Yeah.
Now, if you're willing to travel and you're in Palm Beach, which isn't that where you said you are?
Yeah, but I'm not willing to travel 30 times back and forth. You have no idea.
Who said you've got to travel 30 times? You're making an awful lot of assumptions. I've been listening to you for a long time now. You're making a lot of assumptions, Carl.
So what kind of treatment can they give me in Sylvester that I can't get at Chicago or Palm Beach?
I can't tell you about Palm Beach. What they could give you in Sylvester is what they can give you in Chicago.
Namely,
and if they can do it in 2 or 3 sessions,
right,
it's usually better to have a doctor that's closer to reach if you've got any issues. Now, we treat people all over the country, and we'll send people all over the country.
Yeah.
But we won't send people all over the country for the sake of sending them. There's a lot of people who attend our groups who don't you know, what they don't understand is we're trying to get them to a convenient location quickly and easily. And this, you know, we're not a tour operator here. So if I were you and you living in Palm Beach, and where did you say you are right now?
Well, I'm in Pittsburgh. So Pittsburgh's
Okay.
another area that I could get treatment in.
Okay, well, if you're in Pittsburgh, you can get pretty decent treatment at University of Pittsburgh too. But if it were even up between University of Pittsburgh and the urologist radiation oncologist there and Sylvester in Miami, I would choose Sylvester in Miami.
Does Sylvester and the doctors there accept Medicare?
Yes.
Okay, that's good to know. That's good.
So Carl, I think Rick's question was, where in Palm Beach County do you live? I mean, not.
Are you familiar with Palm Beach County?
Yeah, I'm from Florida. I'm from St. Petersburg.
Okay, I'm at Royal Palm Beach.
Royal Palm Beach. Yeah.
Yeah.
I mean, you're not
near Wellington.
Yeah, I mean, you're less than an hour. I mean, depending on traffic, an hour and a half from Sylvester in Miami.
Well, if I only had to go 2 or 3 times, I could probably handle it. But if it's going to be for radiation, I can get that done locally.
Well,
apparently, that's the best equipment.
If you go with SBRT, which is what we try to recommend, unless there's a reason that you cannot have it. But if you go with SBRT, the most number of treatments you're going to get is 5, and you can probably do it in 4 or even less.
Okay.
So, and you may be with 4+3, you may even be a suitable candidate for some type of brachytherapy. So first of all, we got to figure out exactly where you are, what the doctor wants to do, and we want to get you to the right doctor. Well, I would send you right now, if it were me, I'd go down to Dr. Poonam in Doral, who's part of Sylvester, because he's a great doc. And he'll diagnose and tell you what to do. He'll look at what you've done. He'll pass an opinion. And then from Poonam, we can figure out what to send you to a radiation oncologist. And they can talk to you about the various treatment options. You might be a candidate for seeds. You might be a candidate for high dose brachy. You're probably a candidate for SBRT. So, you know, rather than buckling up on to go down to the airport, Palm Beach Airport, and take a flight or 2 flights to Chicago, buckle up in your car and just like Bill says.
Well,
pick an appointment at a time when there isn't that much traffic, and move on down. The other thing is that Sylvester has a couple of places they treat in northern Miami County, so you may not have to go. You may be able to go down to I forget, is it Deerfield Beach? You may be able to get away with going to Deerfield Beach. That's half the distance.
Okay.
Anyway, I know we've got a bunch of people, so I don't want to continue this too long.
The only thing that I was getting to about this hormone therapy is that what keeps me alive, because of my heart, I've had quadruple heart bypass 12 years ago, and I'm doing good. But I'm more concerned, to be honest with you, about my heart giving out if I don't keep it exercised than I am about the prostate.
Okay, but who says you have to have hormone therapy? Carl?
Well, my urologist is not absolutely requiring it, but from what I understand, the hormone therapy will make me sluggish and all that.
Listen, I did 3 years, 2.5 years of hormone therapy.
Okay.
Bill has experience with hormone therapy. We understand hormone therapy. You want to listen to hormone therapy? Come into the group tomorrow. What I'm saying is you're making assumptions, and your urologist is making assumptions. At this time, we now have good evidence. A meta study came out last week that says the most you would need is 6 months. 6 months of hormone therapy. Could you handle 6 months of hormone therapy? I cannot tell you medically, but I can tell you it's not going to have a whole heck of a lot of effect. It depends on your starting level of testosterone, but don't let the urologist make that decision. It's not her decision. It's the radiation oncologist's decision, and go to somebody at a center of excellence who doesn't have the hat, that doesn't have a hat in the game. Every time you get a hormone shot, she gets paid. And that's a factor when you're dealing with community urologists. So get down, see Poonam, get into the Sylvester system, and let them help you make a treatment decision. How old are you? 70? Did
70,
you say?
yeah.
You know, if you step into Northwestern, they're gonna produce a scalpel as quick as you can say Jack Robinson. Because that's what they do.
What about Chicago, though? What about University of Chicago?
The University of Chicago is quite a bit better, and there are some good. There's a couple of really good radiation oncologists down there. The urologist that we like the best just left to take over at UCLA. But there are other urologists in there that we trust who are good, who don't necessarily push surgery. But, you know, I would encourage you, again, for the sake of a 45-minute to an hour's drive, maybe you can see somebody in Deerfield Beach. I'd encourage you, stick with Sylvester.
I will definitely explore that.
They're up and coming.
When I get back down to Florida. Yes, thank you.
So, yeah, I think that's probably a good approach, Carl, to do from Florida. Rick didn't understand when I said depending on traffic. That doesn't mean the traffic's not bad, Rick. It just means it's less bad. So the driving in and around Miami is horrible. But
listen, Bill. When I had to go, I had HDRC, I had low dose seeds, I had hormone therapy, and I had 25 shots of IMRT, and I had to drive into San Francisco to get it. But I chose to do that at a time in the middle of the day when I knew the bridge wouldn't be backed up either way, and I could get out and back in a quick time. And you set your appointments at times when you think the traffic. You're not going to set an appointment for 9 o'clock in the morning, you know, or for 4 o'clock in the afternoon when you come back and you hit all the traffic.
And my point was, Carl, I wouldn't let the fact that you're hesitant to go to Miami itself stop you from going to a center of excellence like Sylvester. So
I will definitely pursue it, particularly if they do virtual consults. But we'll see.
Okay. So with this, we're going to transition, and Sandra and Amir, we want to come to you. I know you wanted some time and had some questions for us.
Yeah, thank you. Actually, my wife speaks much better than I do, so I'll let her. Yes, go ahead.
Just chime in if you forget your questions. So,
Sure.
So an update, we did get it was actually a third opinion on the pathology from Dr. Epstein. And he concurred on the 4+3 with OHSU, Oregon Health Sciences University. However, he added that the pattern 4 in this case has large cribriform orthology. So that's a new thing that no one else had said before. Other updates, there's kind of some big things. Amir needed to have an angiogram because he'd been having more chest pain. He had a mild heart attack in 2014. He's had 3 stents over, spread out over some time, but nothing for several years. So cardiologist had his stress tests, and then that showed that it was a little bit worse than the last stress test that he had prior to that, which was around 3 years ago. Sent him on for the angiogram. We thought he'd be coming home with a brand new stent number 4 and blood would be flowing better, but it turned out they didn't put any stents. 3 blockages. So I know Carl can relate to this stuff. And they are proposing to do a open heart, coronary bypass surgery. We have a cardiac surgical consult on Friday, this week on Friday, to learn more about that. They could still, like, if for some reason they said if it was more important to, or for his cancer treatment, which is undecided which direction he's going right now. I mean, some sort of radiation, but we don't know what and where. That they could still stent it. It's just they don't prefer to with the situation he has, and because he also has diabetes. They have randomized control studies that show that especially people with diabetes, they have a lot better long-term outcomes if they go the bypass route at this point, because I think with the diabetes, there's going to be more. They tend to have more calcification that keeps recurring over time. So it sounds like it's a huge surgery, but yet it has a better longer term keeping his arteries open result. So that threw a little wrench in the works. As far as upcoming appointments and things, we need to get back to Dr. Peter Rossi in Colorado. He was the one that said he would prefer to give him SBRT or brachy with no ADT, primarily because of his heart. But he also said, it's not stepping outside the guidelines to say with what although he doesn't know about the crib reform yet. We haven't updated him, or we haven't talked to him since we sent him that Epstein's report. He also has a in-person consult if we go ahead and are able to travel to Houston at MD Anderson on the 20th of January with someone that's another doctor and Dr. Stephen Frank's team to talk about all of their radiation type options they have there. The same day, we have a virtual consult with Dr. Kishan at UCLA. And we've also made a medical oncologist appointment here locally with Oregon Health Sciences University with Alexandra Sokolova. That's the same one that David goes to, on December 23rd. And I think that's it as far as new updates. So we're not sure, like the impacts of I know the open heart surgery is a long recovery, and we don't know, say, if he did want to travel somewhere for cancer treatment, how long he would need to heal from the open heart surgery before he could travel somewhere else. And it seems like, I guess the confusing part is like both cardiac and the cancer doctors seem to kind of defer to each other. Although the cancer doctors all say, well, your heart takes priority, which makes sense. But then the heart doctors say, but if you wanted, they're like, well, it depends on what cancer treatment you're going to do, or we don't want to also like limit any options for you on your cancer treatment. So we're just kind of in the middle of sorting all this out. I think Friday, once we have the cardiac surgeon consult, there'll be, we'll know more about this.
If you have any input concerning this, if you have dealt with someone who has had similar situation as far as the heart and prostate,
the same time,
we would love to hear your input or experience or any advice that you might have.
Schmier, do you take insulin for your
Diabetes?
Your diabetes, or on a pump or anything?
No, type 2 is just take metformin.
Type 2? Yeah, so I had a cousin with type 1 diabetes who had an insulin pump, and he had cancer, and I seem to recall that they said that his it could worsen, the side effects of radiation could be worse with people with type 1 diabetes. But if you're not on insulin, that's more like poorly treated diabetes, right? So if you've got type 2 and you're trying to utilize exercise, and if you're on metformin or something along those lines, then it's probably not something that you have to worry about. But on the other hand, you do have a heart condition, so
right.
That's another comorbidity that you should definitely be concerned about. Rick,
your hand up.
Go ahead.
Yeah, I'm so sorry that Dr. John jumped off because he knows a lot about cardio aspects and prostate cancer. It's not his specialty. He's a pain psychiatrist by training, but from his own experience, he knows an awful lot. And he would be a good person to talk to. I am going to put his email address in the chat window, and I would send him a message after this. He's back on the East Coast again now, and say, could he find time to talk to you tomorrow? Because I think that he may have a good feel for the sequencing here. I mean, it sounds like with the large cribriform is more aggressive than small cribriform, and it also accounts for the 4 in the biopsy. So if they see cribriform, they automatically give you a 4. And you're 4 plus 3, right, Amir?
Yes.
So that's where the 4 comes from. Now, the surgeon you're going to see the heart surgeon you're going to see, is he at OSHU?
No.
No, he's at Providence.
Well, again, you see, I would go to OSHU only because OSHU is more likely to have an oncocardiologist on their staff. And oncocardiology is it's not new, but it's a relatively new specialty over the last 5 to 7 years, where the cardiologist takes a particular interest in patients who have cancer and is able to tailor your treatment. So would be somebody who you'd want to involve. If you were talking about hormone therapy, you'd want to be speaking to the oncocardiologist about the impact. So I would really be looking for an oncocardiologist. I don't know if there is one at OSHU. I'm gonna find out. And I'm just gonna text my OSHU lady, who will probably get back to me in about 5 minutes, because that's what she does. She's the new she's gonna be the new chief of GU Medical Oncology.
I think David tried to search he had that same idea a few weeks ago and was trying to search for any in the Portland area. And I don't think you found any, did you, David? There's one at Providence.
I couldn't find one at OHSU. I didn't look all around the city. I was wondering if anybody knew of one on the West Coast.
There's I do. We know of a couple. There's a lady. Funnily enough, also with a Greek name. I'll tell you in a second. I have to look it up because I can't remember. But there's definitely an oncocardiologist at Hutch. Definitely at Hutch, and there is at UCSF. I'm not sure about Huntsman right now. If you give Elaine, you'll give Elaine 12 months and she'll have an oncocardiologist, but you don't have that time. At the same time, I'm going to text her. I was just about to when they called my name, but I'll text Elaine and see if she's got any ideas for an oncocardiologist. But let me put the name of the lady. And that might be worth a little drive up to
Seattle,
up to Hutch to talk to her. She's another Greek fireball, like Dr. F. Stathieu. So hold on a minute and let me get that for you first. She was sitting in my inbox all week because she posted something on LinkedIn that I wanted to look at, and I didn't go to it. So, but yes, those are some of my thoughts. I think that for navigation on this topic, Dr. John is probably really good.
There's
because
a
he's
doctor,
really. Sorry, go ahead.
There's a Dr. Michael Leone. He's with Providence also in our system here. That is apparently, I don't know if he's exactly an oncocardiologist, but he's someone who's trying to work with both departments together. So he's, I don't know what certification you have to be both, but it is someone that I did call about. They basically told me that he'd have to transfer his care from his regular cardiologist over to this other doctor. So we didn't move forward, but that was before the angiogram. It was just because David had that, great suggestion of, with his heart issues, maybe you do want to look at that as a specialty and find out. But I don't know if anyone's heard of that doctor before, Michael Leone. I think he's a cardiologist.
No, it's not really our field.
Yeah.
Give me a second here and let me. Oh, here it is. I've got it.
And I wouldn't rule out OHSU. I just was not able to find one myself. So Dr. Sokolova could tell you that, though.
So let me first, Dr. John at AnCan.org. So here's Dr. John. There's Dr. John's email, and if you knowing John the way I do, if you send him this note, I just actually sent him a text about you. So if you get back to him, and then here's the there's the Andrew. I'm not going to even try to type it in again because it's right there in the thing. Her name is Effie Andrikopoulou. Effie Andrikopoulou.
Okay. Oh, at UW. Okay.
Okay, and she's at Hutch. That UW is University of Washington.
Sure.
Now, she's definitely a specialist in the area.
Okay.
Now, remember, these are oncocardiologists or cardio-oncologists. I think I call them. Remember, those people are not prostate cancer specialists. They're specialists in cancer and cardiology.
Yeah.
But if they're in that field, they're going to understand some of the implications of prostate cancer treatment. And she really strikes me. I mean, look her up on LinkedIn. And she's a ball of fire.
Great, thank you.
Great, thank you so much.
Okay, well, we wish you the best. If there's nothing else, anybody else has any thoughts? Not hearing any others. Tam, I know you had an update for us as well, so you wanted some time.
Okay. Sure. Do you want to ask me the questions or we don't need to?
Are you brand new, Tam? I thought you said you had been here a couple of months ago and had an update for us.
Right. That's right.
So just summarize your
situation.
Summarize your background and then launch into your questions.
Okay. I'm 75 years old and I've had BHP for a long time. I've been followed by a urologist for years, and my PSA was high because of the size of my prostate. This year, earlier in the year, there was a jump in my PSA. I was seeing a different urologist because my former urologist moved, and I'd had various PSA tests over the years, and he thought it was fine to wait. But this year, my PSA started to jump. I ended up seeing a new urologist in Phoenix, where I live now, and he sent me for an MRI, and the MRI came back with high PIRAD scores. And we scheduled a biopsy. The biopsy showed that I had several areas of Gleason score 7, 4+3, and some other areas. I had about they found cancer in about out of about 6 or 7 spots, but 2 of them were more significant with a Gleason score of 7, grade group 3. My urologist started me on, he was because of my age, a condition of a blood problem with bleeding. So I'm an Eliquis patient because I've had blood clots before. And so that's sort of complicated the procedures and various things. And so he had me, my urologist and my doctor, my regular doctor, was ruling out me as a good candidate for surgery. And my urologist was recommending RT with starting out with ADT therapy. And I started ADT therapy 3 months ago. I've been on that with a slight interruption for over some concerns, and that's been resolved. And I had because of the size of my prostate, which was over 130 milliliters, the radiation oncologist that I've seen was recommending that I do a PAE therapy, which is a procedure where they basically block the blood supply to your prostate and causing it to shrink. It's, I guess, a newer therapy that's usually used for just people with who, not for cancer patients directly, but he wanted the radiation oncologist explained that we want a smaller target as much as possible. So I had the PAE about a month ago. That therapy, it went fine. Seems to improve my symptoms and urinary symptoms, and things are fine that way. But 3 months into ADT, I'm facing more symptoms in addition to temperature regulation, fatigue, and some constipation. I'm hoping to resolve that. And I'm scheduled to get markers placed for radiation therapy at the end of January. And then I would have probably radiation therapy starting in end of January or early February. So that's the update. I'm basically looking at IMRT therapy. Rick had sent me some stuff about SBRT, but the symptom management seems more difficult with SBRT, in spite of the outcomes look good, but there's several sources have informed me that the symptom management with SBRT is much more difficult than with under IMRT. So that's who I'm seeing. He does IMRT, that's his specialty. And that's the update. Wanted to hear if people have had experience with ADT therapy before and what kind of symptoms they've had. Does it get worse? That kind of thing. That's my concern. And what the symptoms will be of RT, especially when you're dealing with IMRT, which is a longer less radiation for each session, but a much longer term, and they're talking about 9 weeks. So that's my situation and my questions.
Okay. Hey, David in Portland, do you have an update form or input form? Unmute yourself.
David, you're muted.
Regarding your question about ADT, how long are you going to be on ADT?
It's expected that I will be on ADT until a month after my radiation therapy finishes. So total of about 7 to 8 months,
Okay.
which is considered short term.
Are you able to exercise?
Yes.
Are you exercising vigorously?
I was until a couple of weeks ago when I started to feel much more fatigue, and it's been more difficult to do more vigorous exercise. I'm still exercising, but more moderately.
Well, if your doctor says it's okay to do so, you really need to keep exercising when you feel fatigued. You have to push through that. That's really one of your better options for reducing all the symptoms of ADT. If you're only going to be on it 7 or 8 months, that's not that long, and you can get through it. I just did 6 months. It wasn't a problem. Regarding IMRT, I did that too. I only did 15 sessions because I combined it with brachytherapy, but 15 sessions, I really had minimal urinary symptoms from the IMRT, but there again, I kept exercising throughout. The IMRT won't prevent you from exercising. There's nothing about it that's limiting.
Does it make you even more tired?
It did not make me tired. No.
Oh, okay.
In fact, the day you mentioned you're about to get the markers put in, the fiducials. I had the fiducials and also the rectal spacer put in. The very next day, I did an 8-mile hike. So I'm not necessarily recommending you do that far, but you should be doing with the exercise even more so than cardio is weight training, because the fatigue is partly a factor of muscle loss, and you want to maintain your muscles while you're on ADT.
I've noticed more joint pain than before, especially in my legs. My knees aren't in great shape anyway. They were just wear and tear and stuff. But I've noticed more discomfort in my knees the last few weeks. And
Motion is
I don't know
lotion.
if that's motion is what?
Motion is lotion.
Oh, okay, I like that. That's a nice phrase. So I'll push more on the exercise front. I mean, before this was happening, I was doing some yoga several times a week, and Tai Chi a couple of times a week, and walking. I was doing riding, but in the summertime, riding in Arizona is bad. It's not great. But I'm doing some weight training at home and just trying to keep it up. But the walking has been more difficult because of this loss of energy. I was trying to walk a couple of miles a day, several times a week, and that was working out fine until about a month ago.
I would crank it up on the weight training, and if it were me, I'd crank it up on the walking too, if you possibly can. Try to do some brisk walking, maybe an hour at a time at least.
All right.
Rick's had his hand up for a bit
there. Hand up as well, so I want to bring Rick
right. So there's a couple of things, Tim.
Rick, as long as you're on, I have a question. I did get a second opinion on my biopsy, which you strongly recommended. I spoke to my doctor. He was very happy to do that. He sent it to. He thought he was sending it to Dr. Epstein, but he actually has a relationship with John Hopkins Reference Laboratories. That's who actually did it.
And what did they say?
They came back and they basically confirmed the results of my biopsy at Banner, and a couple of things were a little bit worse. They upgraded a couple of things. They still came up with 2 areas of Gleason score 7, 4+3s,
Right.
and
So,
grade group 3s.
right. I mean, it's okay going to Hopkins, but if we were to put the four people, the four people that we recommend, they would be at the bottom of the list. We'd put the other three above them. The reason it's okay going to Hopkins is because Epstein trained most of those guys.
Right.
But it's not Epstein's eye. And unfortunately, this is all based on the eye of the person looking at them.
Right.
So
did I tell you who the guy was? His name was Hooley Lee.
No, I don't know them. We don't know the people actually in the lab. But it's sort of disappointing that your oncologist is behind the times enough that he didn't realize that Epstein had left. He left 4 years ago. There was a scandal. He left. And then last year he came back and set up his own practice. So that's when we send to Epstein now, it's going to his practice, or we send to Zhao, it's going to Zhao.
Right.
Look, a couple of things. The first thing I would say is whoever's got you on hormone therapy, you don't need to be on. A recent study would suggest that you don't need to be on for more than 6 months. It's a meta study. If you know what a meta study is, that's where they look at a whole bunch of studies and they analyze all the results and they come up with an aggregated conclusion from those studies. I've put the link in the chat window. Just click on that link. You can read the study a little bit later.
Oh, okay, great.
The
I can
last
discuss that with my doctor.
The last author on that study, which means the kind of the managing author who arranged it all, is Kishan, who we've talked about a couple of times tonight. He's a very, very solid, reputable radiation oncologist at UCLA. And the bottom line is that for somebody like you, you don't need more than 6 months. Back in the day, not so long ago, we would have said maybe you needed 9 months or maybe even a year. We don't think so now. So that's the study to pass along to your radiation oncologist, because we may be able to pull you off of you're on Orgovix, right?
Correct.
Taking the pill? Yeah. So we may be able to pull you off that pill 2 months early. And that's really, really significant. The second thing
there's no need to. They want me on it until the radiation starts for sure. Is it normal to be on the? Well,
there's no need to be on there until the radiation starts. In my look, I can't say that. In my view,
it's to suppress the cancer, correct?
Right, but the cancer's been properly suppressed. If it's been suppressed for 6 months, it's not going to come back in the last month or two. And the other thing is let them bring forward the radiation. Don't make you do 2 more months for their convenience.
The reason for that is that a PA therapy, in order to shrink the prostate gland and have a better target for the radiation, that takes 3 months from the time you've had your procedure. And I had the procedure a month ago, so that's why they were waiting 2 more months, so that the gland is smaller and it reduces the chances of side effects.
Okay, so you had a BPH type procedure?
Yes, it's called a prostate artery embolization.
Right, and you did that after you'd started the Orgovix?
Correct.
And then you stopped the Orgovix and restarted it?
No. Well, I stopped the Orgovix for about a week or so because we were concerned about blood clots, because I have a history of blood clots, and they did a scan on me and they were concerned about something, and it turns out that I did not have any active clots.
So I'm still unsure as to how much time have you done on Orgovix right up to now?
3 months.
Okay. And when is the earliest you can have your radiation therapy?
2 more months. The end of January, maybe beginning.
Okay, so that will only be 6 months in total.
Yeah, well, actually, that's correct.
Okay, because
But
you
I
had
was
said
originally
7 or 8
no.
months.
Originally, they told me I would be on Orgovyx until a month after the radiation finished. But you're saying that might not be necessary.
I would say you need to do 6 months, and you know it doesn't need to go through till it's finished. It's going to hang in there, the effect of the Orgovyx, for long enough. Has your testosterone gone down? Have they measured that?
Yes. Yeah, they measured that, and it's next to nothing.
Right.
It's
So it's not going to come back in 2 months. So effectively, you're making your own ADT for the period of that, and I would get off of it at 6 months, and that's what the study says.
Okay, I'll take a look at that study and I'll share that with my
and
neurologist.
share it with your docs. Now, the SBRT, I would disagree with you based on what the studies say. There really is not strong medical evidence that the side effects from SBRT are worse than the side effects from IMRT. And there's been loads and loads of studies on that.
Yeah. The ones that I read said that it's worse initially, but then they level out after a few months.
Well, I mean, it might be worse, but that's what I go on. You know, at the end of the day, is there a difference? Now, if it's not a significant difference, to me, and I don't think there is a significant difference, that's my own opinion. And I did IMRT, I didn't do SBRT because I didn't have it. And I have side effects from radiation. But I put a lot of that down largely to the fact that I had a lot of radiation, a lot more than you're getting, and I had some comorbidities going into the radiation. But for me, I would be weighing 4 or 5 treatments against how many do they want to give you? 25?
5 days a week for 9 weeks, I think.
Well,
that's 40,
there's absolutely no
days.
reason to do 45. You can certainly go with a hypo dose. And I've said this to you before, Tam. Tamir, I think you need a second opinion on your radiation oncologist. I really do. I said that to you originally. I'm concerned. The guy's doing what he knows to do and he knows how to do. And that's not where we are today. We've done a lot of, there's a lot of studies on hyperfractionation. What he's giving you is regular fractionation, which is 45 days. We can probably do the same thing with other docs. It's anywhere from 4 treatments, if you went to San Francisco, to 30-ish treatments. And to go with 45.
Interestingly enough, he indicated to me that he would entertain a shorter treatment of what do you call it? Increased dosage. You know, you're called hypofractionation. Yeah. He says that would be fine if my target was small enough. Depends upon what the results are from my.
Okay, so he's saying, well, because you got 130 gram, I would get a second opinion. That's exactly what I get a second opinion on, from a really strong radiation oncologist Kishan at UCLA or Roach at UCSF, and say, what's the best thing to do here? You're not getting state-of-the-art treatment in Phoenix. Now you can say that's fine. I'm willing to deal with it. I'm willing to go with it, but I want you to know you're not getting optimal treatment, and you're not getting the best advice in Phoenix. You need to go further afield.
Do you have a name of somebody? You don't think there is anybody in Phoenix that would be an alternative to talk to?
In Phoenix?
Yeah.
I don't. I could get you one. I could write to Dr. Boyce and see who he likes, and he usually gets back to me pretty quickly. I can drop him a line in the morning and see what he says. But if I was in Phoenix, I would either go to Keishan.
You said Keishan's at UCLA.
Yeah. And I definitely, we all like Keishan. He's really good. I'd go to Keishan at UCLA. Now he does, correct me if I'm wrong, Stuart, because I'm not great at this, but I think he'll do SBRT in the tunnel, right? Doesn't he do SBRT
Yes.
in the tunnel?
Yes.
So
yes.
MR
Linac.
Yeah.
MR Linac. He does. It's MRI guided radiation, which can be fewer treatments, and it has better safety precautions.
Yeah. So you could do MRI Linac, Linac. Stuart, can you put MRI Linac in the chat for us? And stick Kishan's name. And do you have his URL? If not, I have it. So I would talk to him. You may be able to get done with, and I would trust Kishan. I truly would. I would meet with Kishan, see if he thinks he can deal with you with MRI Linac, and it might finish up with 4 treatments in UCLA versus 45. Now, I realize that means you've got to stay in LA for a couple of days, but it's worth a month not having to go back and forward to the hospital.
Mm-hmm.
So
I didn't see any information on their names in the chat. Is somebody going to send that to me?
Put it in. Give him a chance. He's working on it. He'll get there. If not, I'll put it in a second. The other person I would want to talk to you is.
Wait, what was the name of the guy in Phoenix again? The name of the guy that you know?
Oh, the guy I know is a genitourinary medical oncologist. And that's why I would write to him and ask him who he likes. He's not a doctor that I would send you to right now. Okay.
Okay. You're going to contact him and you can send me
I will
if
send him a note. He used to be at Mayo. He's now in the City of Hope system.
Mm-hmm. And
I would just say to him, who do you think, who's your favorite? Who's your favorite radonc for prostate cancer? And, say, look, jump with 130 grams. He's already been on Orgovix for 3 months, and this doc wants to do 45 treatments. We think he can get it done in a much more patient-friendly way. So, I can do that. Now, the other guy I'd send you to was my own doc, who's up at UCSF.
Well, Keishan would be much more convenient
more convenient, and he's just as good. So, I don't want to don't knock yourself out. Go to Keishan, tell him you're an AnCan person because he knows us, and see if you can get there. Stuart's put Keishan in there.
Put it in there already.
Yeah.
Yes.
Yeah. Thank you. I see that.
Hey, Rick, this is Paul. Can I add something to what you said? I can't figure out how to raise my hand for some reason.
There's an MR Linac. What is that was written after?
MR Linac.
That's the name of a person?
That's the name of the type of treatment. Stuart, you want to explain that treatment a little bit?
It's similar to SBRT, except it's done in an MRI. And as a result, the MRI is real-time monitoring the position of everything. And if it moves out of position, it immediately stops the treatment until it readjusts. So it allows them to have more precise targeting, and it also reduces the risks of radiating outside the target area. And
Okay.
depending on how many sessions he does, he may be able to do it in even less than 4.
And Keyshawn does this?
Yes.
Yes.
Oh, so he's a radiation oncologist. He's not just a urologist.
He's a
Yeah.
he's not a urologist. He's a radiation oncologist.
And
Okay.
the other thing that if you're going to look at any sort of SBRT, they can run a prostox test. Paul just posted that, which
Yeah.
predicts the long-term risk of side effects, which is only occurs in a small percentage of the population, but they can identify that in advance to reduce that risk for you as well.
Hey, can I add something to that?
Yes, Paul.
Yeah, sorry, I couldn't figure out how to raise my hand for some reason. So basically, so if you go to Keyshawn, pretty much he automatically will order a prostate test for you. I had a phone consult with him before my treatment, and without asking, he ordered it for me. So that's a good thing. And he is a good doctor.
Okay. Thank you very much, guys.
Okay. Let's go back to Steve. We want to finish up with you, Steve. You had 1 or 2 questions, I think.
Yeah, I guess sort of double clicking on some of the radiation kind of stuff. I mean, Stuart was kind of following a lot of that. So I hadn't really considered radiation much because I was very focal focused before. What things besides the prostox and of course picking the right doctor should be factored in that kind of decision, you know, as to whether to do it or not? Any thoughts?
Well,
Let's see if I can.
Go ahead.
Go ahead.
yeah, I would focus on a center of excellence, because you're going to get the docs who have the most up-to-date and process in terms of the way they do things. My doctor at MSK, is also on the forefront in terms of MR LINAC, and they're able to reduce the number of sessions because they can actually, it's been tested and proven that they can give you more radiation in a single session and reduce the number of sessions, and without any problems or any risks. Matter of fact, fewer sessions may actually be better for you in terms of reducing your risk of side effects.
Okay.
So I'd really look at. I'm sorry.
Who is the doctor at MSK? Your doctor?
I'm blanking on his name.
Nagar.
That does,
Nagar.
yeah. Nagar, Nagar. He runs the MR LINAC program at Sloan Kettering.
Okay. Great. I think before I was going to ask about Decipher, but I think I got the info on the chat, so I think I'm good.
Okay. I think David in Portland, did you lower your hand? Yeah, it looks like you did.
I
Okay.
actually had a question for Stuart. With MR LINAC, do they even need to do fiducials and a rectal spacer?
No on the fiducials, because the targeting of the with the MRI removes the need to do that, because they can see what they're looking at. The rectal spacer is on a case-by-case basis with Dr. Nagar. Depends on where the focus is. It depends on your underlying health conditions as to whether you have bowel issues or concerns. And for me, the answer was no. For one of the other guys here in this group who's not here tonight, the answer was yes. So it's case by case basis.
Thank you.
Tamir, when did you say they're supposed to put in your fiduciaries? You muted.
Muted, Tamir.
Sorry about that. The end of January.
Okay, so you got plenty of time. You got plenty of time to go see somebody like Kishan before, because we don't want them sticking in those fiduciaries if we find out we can get around it. Okay, that's all I'm saying.
Okay.
And for Tamir, I got some good news. You were wise to go with the Orgovix because it wears off a lot quicker once you stop taking it than Lupron does.
Yeah.
Right.
Yeah.
Yeah, that was talked about last time I was here.
Okay.
Right. Some people have been mentioning Prostox, and Paul brought it up, and others. That is a test. It was developed at UCLA by Dr. Widerhaas. If you put Prostox into our search engine on the AnCan site, she gave a whole seminar on it. So she's going to be able to tell you about it. And what it does is tell you whether you're a suitable candidate for SBRT. Some people are not. Some people are likely to have more side effects. And so we recommend that Prostox test is a good option. And if it comes back and you're not, then you revert back to IMRT. But then the question is, how many sessions? And, who's going to be the best doc to deliver it to you? Because even the difference between 30 and 45 days is a lot. That's 2 weeks.
Hey guys, I'm gonna suggest we call it an evening. This has been a great video chat, and I thank everybody for hanging around. It's been really informative, and I want to say thank you for all of you. We meet again in 2 weeks, the same channel, the same time.
Yeah, I'd like to, emphasize that you don't have to hang around until we turn the channel off if you got something else to do, but we appreciate everybody hanging around until the very end. It kind of lets us think that you value what we're presenting to you, what we're trying to help you with. So we're glad we can help. I had something else to say and I forgot what it was. Oh, what Rick just said about the 2 week difference between 30 and 45 treatments, I'll just close with that. All my radiation treatment issues started at the end, right? Like the last 7 or 8 treatments, almost to the point where the doc was saying, do you want to stop? Silly me was, let's get it done. There's only 8 more treatments, right? So I probably should have stopped. But all right. Everybody have a good night.
In our recording, thank you, everybody.